Hello, welcome to the Roadeo webinar entitled Using Data to Impact Oral Health Policy, What Policymakers Want to Know. I'm Annalise Cothran, Roadeo Coordinator. Dr. David Capelli, Roadeo Director, is unable to attend the webinar but extends his warmest welcome. We thank you for joining us today. I thought we would start by giving a little background for those of you who may not be familiar with Roadeo. The repository of oral health data for evaluation and outcomes is a statewide database of basic screening survey oral health indicators, access to care information, and demographic data. Programs across Texas contribute data annually. Each year, data are synthesized and published on the Roadeo website for public access. Roadeo is a partnership between UT Health San Antonio School of Dentistry and the Texas Department of State Health Services Oral Health Program, supported by funding from the Health Resources and Services Administration. This webinar series aims to bring dental public health information and initiatives to both Roadeo users and contributors, as well as national partners who are interested in learning more about the oral health of Texans. You can learn more about Roadeo by visiting the website www.rodeo.org. This webinar is the fifth in our series. Previous webinar topics include collaboration on health IT, public health messaging in a digital era, older adult oral health programs, and access to care data presented by the ADA Health Policy Institute. As mentioned, this webinar is being recorded and will be made available for review later on the Roadeo website. You can view any of our previous webinars on the Roadeo website under the Webinars tab or on our Roadeo YouTube channel. We are also on Facebook and Twitter. Follow us on social media to give us your feedback on the webinar and tell us what you'd like to see in future webinars. We are excited to keep the conversation going. Lastly, I would like to mention that Roadeo will be presenting at the National Oral Health Conference in Louisville, Kentucky on Tuesday, April 17th from 4:30 to 6 p.m. If you're attending NOHC and would like to learn more about the process for developing a statewide oral health data repository, mark your calendars and join us for the workshop. Before we start, I wanted to review a few housekeeping details. This webinar will last approximately 45 minutes, after which Dr. Brand will answer questions. If you have a question, please type it in the question box. If typing in the chat or question feature, please make sure that you're typing to the entire audience or sending to all. At the conclusion, the presenter will read and answer questions. If she does not have time to answer your question, or if you have a follow-up question, we will be happy to provide Dr. Brand's slides and contact information on the Roadeo website. You can also email us at rodeo@utesca.edu, and we'll be happy to connect you with the speaker. This webinar will provide an overview of how to use data to promote oral health legislation and policy when engaging federal legislatures, administration officials, and policymakers. The presentation will highlight the kinds of actions that these groups can take, such as regulation, legislation, and administrative action, and how they use data to inform decision-making and program evaluation. Dr. Brand will highlight how oral health champions can prepare to interact with these individuals. Dr. Marcia Brand was the Deputy Administrator of the Health Resources and Services Administration, or HRSA, from 2009 until 2015. In previous federal appointments, she led efforts to plan and implement the State Planning Grant Program, which helped states explore options for providing healthcare coverage for uninsured residents, and coordinated HRSA's efforts to implement the Children's Health Insurance Program. Dr. Brand worked in the U.S. Senate as a legislative assistant and held academic appointments in the dental hygiene departments at Thomas Jefferson University and Old Dominion University. Dr. Brand now works as the senior advisor to the DentaQuest Foundation and as a consultant and advisor on matters related to oral and rural healthcare. Please join us in welcoming Dr. Marsha Brand.
Well, good afternoon. And Lisa, I'm looking at slide 12. There we go. Thank you. Good afternoon. My name is Marsha Brand, and it's my privilege to be with you today. As Annalise said, I worked in the Senate for 2 years. I worked for Senator Robert C. Byrd from West Virginia. I was his legislative aide. I managed health and education issues for him in the beginning. And then I was assigned agriculture and veterans affairs. You have to be a quick study to work in the Senate. I also had the privilege of working in the U.S. Department of Health and Human Services for 24 years. I was a grant program manager. I was a bureau director. I was a senior advisor to a deputy assistant secretary. And at the end of my career, I was deputy administrator at HRSA, which means that I was the senior career official. So I have been a federal policymaker in 2 branches of government, and I have some sense for what those folks need to hear in terms of credible and timely data to inform their decision making. And I'm hopeful to be able to share some of that with you this afternoon. So next slide, please. So this presentation, today we're going to discuss data for informing policy makers. And I want to begin by noting that this is principally focused on the federal level, and I recognize that state engagement is really important too. If we think about issues such as oral health, scope of practice for providers, or Medicaid, so it's really important to be engaged at the state level, but today we're just focusing at the federal level. I'm also going to be talking a little bit about the difference between advocacy and lobbying, so you can answer this question, now what am I doing? A quick refresher on civics, what does the executive branch do and what does the legislative branch do, and who are the policymakers in these branches. I want to talk to you a little bit about the research that we use to inform those policymakers in an ideal process and otherwise, and then determine what kinds of data are most helpful, and talk a little bit about data sources for oral health. So let's begin by talking a little bit about advocacy versus lobbying. For anyone who's really interested in going further in detail on this topic, we're going to do an Oral Health 2020 Take 20 on May 1st about advocacy versus lobbying, so stay tuned for that. Advocacy is basically the process that you use to make your voices heard on issues that affect your lives and the lives of others at the local, state, and the national level. The goal is to help policymakers find solutions to those persistent problems. Most nonprofits can and do engage in advocacy to achieve their goals, and these are a couple of examples of advocacy. You might tell your member of Congress how a federal grant your organization received has helped his or her constituents. So for example, if in your community there's an FQHC, a community health center, and it received resources in the 2016 expansion to expand its oral health services, you might go to your congressperson and tell them how important that was, and you hope that she or he will continue to support FQHCs. You might educate a member of Congress about the effects of a policy on his stakeholders or constituents. For example, you might tell a member of Congress about the importance of getting some Medicare coverage for our seniors. Next slide. So lobbying. I guess it's important to begin by saying that lobbying kind of gets a bad rap, but if there were no lobbying, it would be impossible for our policymakers to have different perspectives, and we would not have informed leadership. So let's talk a little bit about lobbying. Lobbying involves activities that are in direct support of or opposition to a specific piece of legislation that's already been introduced. Nonprofits can and do engage in lobbying, but IRS has some pretty strict rules about the proportion of their budget that they can use for these activities. And it's also important to note that there are prohibitions on using any federal funds for lobbying. The idea is that you can't use federal money to get federal money. States may have additional regulations, and so it's important to check with your state. And here are a couple of examples of lobbying. If you ask a member of Congress to vote for or against, or amend a specific piece of introduced legislation, that's lobbying. If you email a call to action for your members and urge them to contact their members of Congress in support of an action or a legislation that's been introduced, that's lobbying. And if you are preparing materials or organizing events in support of a particular bill, that's lobbying also. So who are we trying to influence? We're trying to influence and trying to make oral health champions out of members of Congress and their staff. A couple of comments about Hill staff. Often the person who's going to meet with folks at the Hill are disappointed because they end up meeting with the staff rather than the principal. And it's important to note that the staff decide what the members see and who the members see. So the Hill staff are really important in this process. You may meet with administration officials and their staffs. These would be the career officials as well as the political appointees. And there are other policymakers and opinion leaders that we might want to influence around oral health. Think, for example, Academy Health or the National Health Policy Group. And once again, I just want to make the point that we need to engage states, but today we're principally talking about federal engagement. So who do you engage in Congress? You can engage your congressional delegation. You have 2 senators, and your delegation has representatives. You might engage lawmakers on committees of jurisdiction, which means in congressional speak, this is the committee who has responsibility for this matter or this policy issue. So just a couple of examples. Dr. Mike Monopoly and Pat Finnerty and I went to meet with the Senate Special Committee on Aging, their staff, about oral health for seniors. That would be the Committee of Jurisdiction for Aging. We also had a chance to meet with the Senate Veterans Affairs Committee around oral health access for veterans. That's the Committee of Jurisdiction for Veterans. There's some general agreement about the key committees for health and for oral health, and so we'll talk a little bit about those. There are a couple of committees that are sort of the same in both chambers. The Appropriations Committee allocates discretionary money on an annual basis for non-entitlement programs. The entitlement programs are Medicaid, Medicare, and Social Security. It has a subcommittee on health, and it has jurisdiction over oral health, dental education, and research. It would help to determine how much money is spent on the dental workforce, maternal and child health, community health centers, and CDC-based, state-based programs. Just to note, the folks in the House Appropriations today have introduced an omnibus spending bill that hopefully will get us through the end of the federal fiscal year, and they have sent it to the Senate, so they're really busy. The government runs out of money on Friday if they don't get this completed, and a really quick read showed that a lot of the programs that we care about in oral health are pretty much level funded, and there's a pretty significant plus up for addressing the opioid crisis. Another thing to note about appropriations committees is that they provide the dollars and they also provide the directions. And so they say how much money is made available, but they might also direct a particular agency to address a challenge or not to do something. For example, in the HRSA appropriation for a number of years, there was language that said no part of these funds, that were funds being made available for the dental workforce, could be used to support the training of dental therapists. There are budget committees in each house, and they set the spending and taxing priorities for the government. They tell the appropriations committees how much they have to spend and how much they're going to need to raise. And generally, they are responsible for an annual budget resolution. At this time, we have a 2-year budget agreement, which is kind of unusual, and we still don't have an appropriation. So there's work yet to be done in the chambers related to federal year that we're in FY18. In the House, these are the committees that are most important around oral health in the House. The House Education and Workforce Committee, it authorizes the programs and policies from pre-K through higher ed and the poverty programs, and addresses labor issues. And so this would have an impact on the dental workforce and student loans. House Ways and Means and House Energy and Commerce have a little bit of overlap. Both have a subcommittee on health. Ways and Means principally focuses on tax laws and authorizes many of the major government programs. So think here, Social Security, Medicaid, and Medicare. House Energy and Commerce is focused on biomedical research, health and health facilities, public health, quarantine. So they have a little bit of overlap in the House on their committees of jurisdiction related to oral health. In the Senate, I guess it's fortunate the acronym for the principal committee for oral health in the Senate is HELP. It's Health, Education, Labor, and Pensions, and it authorizes the education, health, and public welfare programs. This would include biomedical research and development, public health, student loans, higher ed, and most of the health-related agencies except for the entitlement programs such as Medicare and Medicaid. So if we continue our civics refresher and talk a little bit about the administration and healthcare, I want to first encourage you to, if this is a topic that you're really into and you want to get into the weeds, there will be an Oral Health 2020 Take 20 webinar on an overview of the administration and oral health activities. And so it's April 3rd, so mark your calendar if you really want to get into this in a big way. Today we're just going to hit the high points. So if you look at the way the administration is organized, it's organized into operating divisions, and these are the agencies, and staffing divisions. This is the administration. And so if you want to use the lingo, there are opdivs and staff divs. And so we'll first talk about the staff divs. And this is within the U.S. Department of Health and Human Services. And the chief executive officer is the secretary. This individual is a political appointee, a member of the cabinet, and currently that position is occupied by Secretary Azar. The leader of the U.S. Public Health Service Commission Corps is the Surgeon General. This person is the leading spokesperson on matters related to public health, appointed by the President, and the Senate confirms this individual. And right now, our Surgeon General is Dr. Jerome Adams. And then as you get into the department, you get into a fairly complex organizational structure. There are assistant secretaries, so there are assistant secretaries for health, administration, planning and evaluation, preparedness and response, and public affairs, and others. There are deputy secretaries, and then there are P-dashes, which are principal deputy assistant secretaries. And so it's a little bit confusing, but the ones that are probably most important to what we do would be the ASH, which is the Assistant Secretary for Health, and the ASPE, the Assistant Secretary for Planning and Evaluation. And if you take a look from at the sort of highest level of what HHS does around oral health, it develops strategic plans. Think Healthy People 2020. We're well on our way to developing Healthy People 2030. HHS just released a strategic plan to cover the period of 2018 through 2022. Congratulations to the folks who engaged HHS on that, because originally there was nothing about access to oral health care, and it now contains a couple of goals specifically related to increasing access to oral health care. HHS develops policies and regulations, supports public health assessments. It develops and submits its budget to OMB, which is how it communicates its priorities for health and oral health. It implements programs by holding the opdivs accountable. And one thing I think many folks know, but we need to think about how we could engage more effectively, is that there is an HHS-wide oral health coordinating committee with representation from all of the opdivs, from HHS, and a number of the other services within the federal government. So there's a group called the OC that we might want to engage as well. So at the highest level, talk a little bit about the operating divisions and what they do related to oral health. They are principally led by administrators, and then at the next level you have directors and bureau and institute leads. At the next level you have branch chiefs, and then you have program officers. And so we could engage to be advocates for oral health at any of these levels. The OPDIVs, the operating divisions, are organized by legislative authority and program focus. And the ones that probably have the most direct impact on oral health are CMS, because it administers Medicare, Medicaid, and CHIP. It's principally a regulatory agency. One of the things that we could do is provide comments when they are making regulations. That's a pretty common thing to do. The next agency that we might talk about, and the one that I spent much of my career in, is the Health Resources and Services Administration, or HRSA. HRSA makes grants to support health centers. One of the things to note is that health centers serve more than 26 million people, so they're very influential. This is a way to be really influential around policy. In 2016, they saw 14 million dental patients. And the good news there is that's up 56% from 2010. HRSA also manages the workforce development programs, maternal and child health, the Ryan White HIV and AIDS programs, and it's the home for the Federal Office of Rural Health Policy. CDC is well known to many of you for its oral health programs, and specifically for support to states. The NIH has a very important role to play around oral health. It principally addresses oral health through the National Institute of Dental and Craniofacial Research, but a number of the other institutes also look at issues related to oral health, for example, the National Cancer Institute. And the last of the sort of 5 big players is the Indian Health Service, which provides direct patient care and also collaborates with tribes to provide oral health services across the nation. So what do you ask these folks for? If you're talking to a member of Congress or a senator, you're going to be asking them for something related to the authorizing language or the appropriating language of a particular bill, or in general, asking that they be helpful in advancing some aspect of oral health. So we might ask them to be supporting improved oral health as advocacy, but if you're asking them for a particular, something that's particular to a current legislative action, remember that's lobbying. We would ask them for their leadership on matters, both authorizing and legislating language. And I think it's important to remember too that we need to create some oral health champions. For a number of years, a really important oral health champion for us was Representative Elijah Cummings from Maryland. He was an advocate for oral health, and has been, because Diamante Driver was a young man who died from a brain abscess related to his dental abscess, and was in his district. And so hopefully some of you got to hear Elijah Cummings. If anyone was ever destined to be named Elijah, it was this man. He's a very, very effective advocate. And then Mary Otto moved this story into the Washington Post, and now we have Mary's book, Teeth, that talks about the need for oral health champions. Another significant oral health champion has been Senator Bernie Sanders, but he's been busy for a couple of years, but he has in the past introduced legislation related to oral health. And so when we go to talk to these policymakers, we ask them, we use this as an opportunity to tell them about successful programs and investments. When we go to talk to the administration, we're asking for some different things. We're asking them to support policies, programs, innovations, research, things that are within their scope of legislation and regulatory authorities that impact oral health. And we are here looking for a chance to tell them about successful programs as well as problems. And in general, when we work with policymakers, we want them to be aware of your concerns and the proposed solutions, and we're looking for their influence. And to do this, you need to ask, and this is where we get to the data. You're going to need data that effectively supports your policy solution. So what do they want to know? These are the basics. They want to know what the problem is. And the problem, I just want to emphasize in all caps that problem identification is really important. They're going to want to know, how does this affect my state or my district, and particularly how does it affect us compared to others. The policymakers are going to want to know what the solutions are. They would want to know the impact of this action or not doing anything, and what would that impact be on my stakeholders. They're going to want to know what it costs in the short term and in the longer term. And they're going to want to know what happens if we don't do anything. They're going to want to know who can be helped. And just to note, when at all possible, they're going to want their data to be simple. If it's really complicated, if there are lots of tables and lots of explanatory footnotes, generally the policymakers are going to struggle, and you want it to be really easy for them to serve as your advocate. So a few other things that I would suggest that you have in your pocket. This is sort of insider information. You need a really polished ask. People call this the elevator speech. And the reason it's particularly important when you're going to meet with a federal policymaker is that the principal, that's the most important person in the room, may not stay very long. They're really busy. And if you spend a whole lot of time in the wind-up, they may never hear what it is that you're asking for. So you need to try to get it out there pretty quickly. And don't be disappointed if they say that's an important issue, we'll follow up with that. And so, Dr. Brand, will you meet with this group afterwards? That's not bad. That's good, because the staff, remember, get to determine what the principal hears and who they see. So you might get an opportunity to come back again. They're going to want to know from you why this is the best approach, and they're going to want to see data that can support that view. They're also really going to want to know how potential stakeholders are going to feel about this issue. So you're going to want perhaps to have personal stories. You know, it may be possible to take someone with you to meet with this principal. If you are meeting with folks who are lawmakers, that's a great idea. Senator Byrd would often take a meeting because someone from the state was there. Folks in the administration are going to ask, what does the field think? What are the grantees how are they going to respond? Another question you're going to want to be able to answer is, who else is going to care? What do other people in my agency or part of your delegation feel about this issue? Mr. Byrd had this practice that when there would be a vote called in the Senate, he would come find his Senate staffer, and on many occasions that was me, and he would say, you know, Marshall, what is this? And I'd say, Mr. Byrd, this is a measure to do the following. And then he would ask me the position of members on the Committee of Jurisdiction. What do they think? He might ask me about individual members of the Senate with whom he had a strong relationship. He might ask me about leadership in the Senate and in the state, where the folks in the state on this issue. And then it's not uncommon for him to say, where is Mrs. Jones of Cabin Creek, West Virginia? And I'd be off looking for a phone, calling Mrs. Jones and ask her what she thought about a particular legislation. And I'm sure that Mrs. Jones was thrilled and went to church later that week and told everybody that Mr. Byrd had called her before he cast his vote. So they do care about what others think. They're also going to ask you if there's been bad press or good press about this issue. They're going to ask about winners and losers. And once again, they're going to ask you what evidence you have to support your position. So data. The data that you need to make your oral health case to federal policymakers should be both quantitative and qualitative. You know, it's great if you can drill down to the state or local level. Like I said, there's compelling stories. Dr. Michael Meek tells me that this is what he thinks, is that data make you credible, and stories make you memorable. A little thing to keep in mind. The other thing I would encourage you to do is be persistent. Sometimes ideas don't get traction, or sometimes you don't make much progress because you're out of cycle, for example, and a piece of legislation is not up for reauthorization for a couple of years. You know, you may be asking for something in a year that's a really tight budget year, and there's just no wiggle room to fund your project. And it's also true often that you need to build scale. You need to be able to demonstrate that there's considerable interest in this particular topic area. So using data to impact oral health policy, what kind of data do you use? And this is a bit simplistic, but pretty much in this order. This is sort of a rank of credibility. It's an official survey or goal or benchmark, particularly if it's a federal goal or benchmark like EPSDT, sorry for the typo there, for Medicaid data for kids. So that's an official survey, and you can compare year over year. Data that are developed and derived from CDC, CMS, HRSA, the HPSIS, Health Professional Shortage Areas, other federal and state agency data. Third on our list is policy-relevant peer-reviewed academic journals like the Journal of American Medical Association, New England Journal of Medicine, or Journal of American Dental Association. The next data source would be professional organizations like the ADA or the AMA or ASTO. One thing to know is that because they are advancing the needs of their members, they tend to pick and choose the data that they use a bit to promote their position, so they're a little less trusted than some of the other data sources. Certainly, we often go to Kaiser and Health Affairs and other nonprofits. They're a little mistrusted by some folks who view them as liberal-leaning. And then every once in a while, there will be a really credible source that doesn't routinely address oral health, but comes out with an article that you might be able to use, for example, the Wall Street Journal. So the ideal, ideally we would have science-informed health policy development and implementation. If I were a health services researcher, I would want to have a traditional approach, and we would use these data to support federal health policy by identifying problems, researching the benefits and harms of the different solutions, estimating the costs and consequences of these programs, and the researchers would be actively engaged in the policy process so that there could be real-time decision making. This council, if you look at the authors here, comes from Carolyn Clancy, who was at one time the director of the Agency for Healthcare Research and Quality, Sherry Gleed, who was the HHS Assistant Secretary for Planning and Evaluation, and Nikki Laurie, who was the Assistant Secretary for Preparedness and Response. And I can just imagine the three of them sitting there and thinking, wouldn't it be wonderful if we had data that identified the problems and researched the benefits and harms of the solutions and the costs and consequences, and that we got to help to develop it. That's not often how it happens, but I can understand why they might want it to be that way. Next slide. Their council, if you want to penetrate the policymaking process, 3 women who have been there at the highest level and would know, you need to have data and the logic that can be easily explained. The design of the study needs to be pretty straightforward and needs to be easily understood by someone who's a non-specialist staffer here. So we would be reading my editorial comment, political science. This person may not have spent a lot of time reviewing health services research. They also encourage you to try to make it something you can visualize. And once again, they're looking for those compelling narratives. So kind of the exception to the keep it simple rule is when you are developing data to inform the budget makers. The costs and consequences are how they determine their outcome, and the budget folks really get into the weeds. They ground their estimates in public literature, the research that's really rigorous. Think here about the congressional budget offices when they are scoring the cost of a bill. So they're much more likely to get into the complicated analyses than perhaps other folks that you might be preparing to engage. One of the other things that's kind of unfortunate is that there's really not much time sometimes between when you identify a problem and when you want to address this challenge, and so it's a short time for summarizing and applying scientific knowledge, and I'm sure that Carolyn, Sherry, and Nikki wish they had this information in a more timely way. This is why I think it's really important to create data banks. Can we create a repository of data that supports the policy work that we're engaging in? I'd like to commend the folks in Texas for addressing this significant oral health data need in your state. They're the folks who sponsored our webinar today. And as we look at oral health data for informing policymakers, we see some pretty long-standing challenges. The oral health data collection that we do now varies widely across states and the sources and patient types. Often there's this often we try to use the presence of a dental provider as a proxy for access. You know, we look at the dental HIPSAs and go, oh, you know, this area is underserved, whereas there might be lots of other areas that are underserved because this provider doesn't see folks who take Medicaid or another provider type. So that's a challenge for us, is not just using the presence of a dental provider as a proxy for access. For many years, dentistry has practiced separately from mainstream medicine, and as a result, has not been engaged as much in the development of quality measures, and we've been kind of slow to adopt electronic health records and other information systems, and so we don't have as good a data sets as others in healthcare. But there is some good news. A couple that I'd point out. One is that the ADA has sponsored the Dental Quality Alliance, and it has 3 objectives. You can see them there. Looking at developing evidence-based oral healthcare performance measures and resources. It's looking to advance the effectiveness and scientific basis of clinical performance and measurement, and to foster the support of professional accountability, transparency, and value in oral healthcare. And so kudos to the ADA for this work. A little bit more good news about data and measurement in oral health is the Oral Health 2020 Network, which has been supported by DentaQuest. It has as a goal to build a comprehensive national data health system, and a couple of the tactics toward that goal will be to engage national partners to develop consensus around a core set of measures that has sufficient granularity, and we need a measurement reporting strategy, and they're hopeful to be able to release the first comprehensive national survey and report on the nation's oral health. And I guess since it's Oral Health 2020, we're going to do that in 2 years. It's a very ambitious undertaking. There are also some pretty credible data sources that you could use to inform oral health policymakers in the states. I highlighted the Roadeo Project. One thing that's happening right now that's particularly interesting is in Massachusetts. They are trying to pull together community health centers and look at how to measure medical dental integration with metrics and quality improvement as the focus. And it's been really hard to measure integration, so I applaud them for that. And then the Association of State and Territorial Dental Directors have some pretty good data sets about state level data for informing oral health policymakers. And kind of winding up here, at the national level, there are some useful tools. I ran the Federal Office of Rural Health Policy, and so I always start with a rural example. There's a rural oral health toolkit that has a number of reports that you could use to inform policymakers about the oral health needs of rural communities. There's an ADA Health Policy Institute data center that you could go to and get data. And that's a really useful source. And then something that's come along over the past few years, supported by the Robert Wood Johnson Foundation, is county health rankings. And so what this is a state and county-based sort of snapshot of a community's health, and it's a really good way to start discussions around the social determinants of health. So on the state and county level, you can get information about poverty, educational achievement, life expectancy, tobacco use, Access to care, once again, they're using dental providers as the metric there. But it's also lists promising practices for addressing some of these challenges. So I would encourage you to look at the county health rankings. It's not quite as strong for rural researchers because the sample sizes may be a little bit smaller, but it's a really useful tool to get a snapshot of what's happening in your county or in your state. So a couple of other sources to be thinking about come from CDC. The NHANES data, which is the survey of the nutritional status of adults and health status of adults and children. There are also a couple of sites at CDC where you can get information arrayed in a way that might be particularly useful to you and straightforward for sharing with policymakers. If you're interested in the oral health workforce, HRSA funds a workforce grantee that specifically looks at oral health. It's SUNY Albany, and there's the link there. And if you go to their website, there are lots of really interesting studies that they have done over the years to take a look at the adequacy of the oral health workforce. If you want to learn more about the OC, the HHS Oral Health Coordinating Committee, they too have a website to go to, and it highlights information from across the departments. And so perhaps rather sometimes easier than going to each agency individually, you could go to the OC site and see what they've posted there. And then, of course, we can always go to our friends at CMS to get information about Medicaid and CHIP. So I want to thank you for the opportunity to talk with you today. And again, if you want to know more, those two Oral Health 2020 Take 20s, on April 3rd, the role of federal agencies and regional offices in oral health care. You may not be able to go DC, but there are 10 regional offices. And on May the 1st, we'll be going more deeply into advocacy versus lobbying. And Annalise, I would answer a few questions, and then I don't think anyone ever minds getting a little bit of their day back, so we'll see how we do.
Yes, thank you so much, Dr. Brand. That was incredibly informative. So I just want to encourage, if you haven't already seen the question box, the way to answer questions would be to type into that question feature, and I'll read them out to Dr. Brand. But first, I wanted to ask Dr. Brand a question that I had coming up during the presentation. I know that you mentioned that when organizations like CMS call for comments, how you could utilize that as a way to influence health policy. And I wanted to ask, in your experience, how effective are those comments? Do they read them? How much do they weigh them in terms of how it might influence that policy?
That's a really good question. I think that CMS and my colleagues at the time genuinely care about the impact that a proposed regulation will have on providers or patients. There's something to be said for the volume of those comments. So if they get 1,000 that say that this is a good idea or a bad idea, that makes a difference. They do roll them up and try to get a sense for what the community that's going to be impacted thinks about. And one of the things I might do in follow-up to this email is reach out to a couple folks who are currently at CMS and get their thoughts about how this process is working and see if they have any suggestions about how we might strengthen our ability to impact the regulatory process.
So a few questions on whether or not there will be a copy of this presentation made available. And so I can answer that one, which is yes. Dr. Brand has been gracious in allowing us to disseminate her slides, which I will do shortly after the presentation. We are also recording all of this information, so if you'd like to review anything, you can do so through the Roadeo website and our YouTube channel, and hopefully that will be made available later today. There was a question that was a very simple question. Someone had missed what the acronym of PDASH stood for. If you wouldn't mind repeating that.
Principal Deputy Assistant Secretary for Health.
Okay. And there's another, right. There is another question, what resources are available for dental integration into primary care?
Great question. This is something that HRSA has been actively engaged on in for some period of time. They developed a set of competencies. And if you go to HRSA's website and just Google and then put in oral health, the page will come up. So they've developed a set of competencies for primary care providers. This happened several years ago. And so if you are a primary care provider and you want to engage in the integration of oral health into your primary care setting, what do I need to know and how do I go about it? HRSA has also been funding a number of grants to support the integration of oral health into primary care, and has been a strong advocate for team-based care, and has been using their workforce resources to drive care in that direction. So those are federal resources that are available to you. Externally, there's Smiles for Life, which is a curriculum free and online for skilling up the non-dental folks, or the dental folks for that matter, into what they might do in the context of their primary care practice. And there's also a guide for the integration that was developed by Qualis, and those both of those have been supported by the DentaQuest Foundation and Washington Dental Services, and they're publicly available.
Great, thank you. Another question, you mentioned some great resources for state data. Can you recommend a data collection program or software for states to utilize?
You know, I'm not a techie person, and so I would think if we could defer that question till I can go back to some folks who might be more facile with the technology. Let's do that.
Okay. Well, and maybe a helpful question, a follow-up question would be software data collection for what kind of data? That might also help you sort of redirect maybe what that resource might be.
Thank you.
Another question, March 2016, HP 2020 had a webinar on adult oral health that focused on a HRSA HAB Part A program managed by my team. It had data on oral health through their funding. However, there's not much data on oral health from HRSA, and it would be good to advocate for more of that since reauthorization has not yet occurred. So maybe a general comment. Okay.
Can you read me the first part of the question again?
Sure. In March 2016, there was a webinar on adult oral health that focused on a HRSA HAB Part A program.
Okay.
Right.
So they're talking about the Ryan-wide HIV and AIDS program that's managed by the agency, and it might be a useful thing to do if we're talking about engaging policymakers, is to go to HAB, the HIV and AIDS Bureau, and ask if you could have an opportunity to meet with the folks who manage data collection and have a conversation about what data we could be collecting or they should be collecting to inform policymakers.
Okay, great. Another question, I know this focused primarily on federal policies and potential avenues to follow on a federal level. But I was wondering if maybe you could follow up with a few bullet points on anything state specific that you would recommend. Is it sort of the same protocol, or is there anything different that you would recognize on the state level for people to pursue?
So that's a really good question. And I was trying to be very careful to let folks know that I think state-based advocacy is really important. That the focus today was at the federal level, so not to diminish the role that the states have to play in improving access and outcomes in oral health. I think that some of the principles that I laid out would be applicable in most states, both in terms of the legislature, that you want to meet with your senators and your representatives by whatever name they're called. That the role of staff are important. One of the things that you would find in the state typically is that they're historically understaffed, and so it's a bit of a challenge for them to manage a very broad portfolio. So once again, the extent to which you can keep your ask pretty defined, provide the data in a way that's useful to them, that in most ways you would engage your state legislature in the same manner that you might the Congress. In terms of approaching the leadership of the state's agencies, a number of them are going to be arrayed in a different way. They may have a Secretary for Health and Human Services, or they may be aligned differently. But once again, I think it is appropriate to reach out and ask to inform your state leadership, your governor, the secretaries, about issues that you are concerned about. And the principles pretty much apply. It's just the structure may be a little bit different. Like the committee structure, in the legislature might be different, and the structure of the administrative elements of the state might be different.
Okay. Well, if there are any other questions, I will forward them to Dr. Brand, but we want to be respectful of everyone's time. So thank you again, Dr. Brand, and thank you to everyone for joining us today. We certainly appreciate your time. We appreciate your information. This was incredibly helpful. And I hope that everyone attending the webinar today will consider joining us in future webinars. We'll have one in April as well. So thank you again, and everyone will be able to access this information by the end of the day.
Thank you.